All right, I want to thank the organizers, specifically Kara and Stefan, for inviting me to speak today. And here are my disclosures. So our objectives for this morning are to understand the efficacy and safety profiles of the current and future therapies for IBD, and to review the most effective treatment strategies today and some approaches for the future. But I want to give the disclaimer that I can only really cover the highlights from Crohn's and UC Care in 20 to 25 minutes, and this may feel like a little bit of information overload, but you'll get an opportunity to really ask questions in some of the breakout sessions. So let's take a look down memory lane about some of the therapies we've been using in the past. Now, it doesn't really show up on this slide so well for you, but this is the menu of options that have been available for Crohn's going back to 1993, where we really had a limited set of options and three-course menu. Going to 2003, where we had a little bit more, but we saved the best option for dessert, which was Infliximab. And now getting to 2022, where we have multiple options in the first course with potential add-ons of therapy, and then some amuse-bouches to go with it as well. In the past, we've really relied on steroids for symptomatic control for patients in the short term. But we know that if you look at the long-term use of steroids, over half of patients are not going to be in a prolonged remission, are going to need surgery and be dependent on steroids. And you really need to have an exit strategy whenever you're prescribed steroids for some symptom control. And the reason for that is the various adverse events that can happen with steroids, from glaucoma to osteoporosis, infections, hypertension, adrenal insufficiency. The name of the game is to get you off steroids. And again, I really want to stress this point throughout, that steroids are not a maintenance therapy. And if you're on steroids for over 3 months, that's a problem, and you really need to be asking questions about going on to another therapy. In the past, we've also relied on 5-aminosalicylates for maintenance therapies for Crohn's disease and ulcerative colitis. But in recent years, we've learned that particularly for Crohn's disease, 5-ASAs are not really effective therapies. We still use 5-ASAs for mild ulcerative colitis, but in Crohn's, the research doesn't support that. And despite that, when you look at claim studies, we see that lots of patients are still prescribed 5-ASAs. And these are just 2 studies in the last 2 years showing that when you progress to an advanced therapy for IBD, there's no benefit in continuing the 5-ASA. Immunosuppressants have been a mainstay of treatment for IBD for over 50 years at this point. They have been shown to be effective for maintenance in both UC and Crohn's disease. But in recent years, with advanced therapies, we see more effectiveness with the advanced therapies and probably fewer side effects even with the advanced therapies. So more and more we're using the immunosuppressants as a combination to add on to biologic therapies as opposed to the sole therapy for patients. And part of the reason is some of the potential adverse events with the immunosuppressants. They can lower your white blood cell count, which is part of the way they work, so we expect that. Rarely you can have pancreatitis, liver enzyme abnormalities. And then the ones that patients most often ask about are non-melanoma skin cancers and lymphoma, which are rare side effects. So let's talk a little bit about what we have currently available for IBD therapy. And really the name of the game with treatment is symptom control, keeping you off steroids, and modifying the natural history of disease to prevent downstream complications. And part of choosing the right treatment for you is characterizing your risk. And we've defined sort of who the high-risk groups are for both Crohn's disease and ulcerative colitis. In Crohn's disease, the high-risk group are patients under the age of 30 who have ileal involvement of their disease. If you have perianal or rectal disease, deep ulcerations, a history of prior surgeries, or having penetrating or stricturing complications of your disease. In ulcerative colitis, the high-risk features which we want to treat aggressively are, again, younger patients under the age of 40, having extensive disease involving the entire colon, deep ulcerations, low albumin on your labs, and elevated inflammatory markers such as C-reactive protein, and a history of hospitalization for your colitis. And the idea here is that if we can treat early in the disease course these patients with a severe phenotype, maybe we can prevent the formation of downstream complications. So this is the paradigm in Crohn's disease where you can develop strictures, fistulas, abscesses, require surgery as your disease progresses. And the idea is that we have a window of opportunity early in the disease course where if we treat then, maybe we can modify natural history. So treat at the disease onset, maybe this can prevent these downstream complications from happening. Now, we have many more available therapies these days for IBD than early in that menu of options I showed you. And we're living in a TNF world and then a post-TNF world. So before 2014, we were really only had the TNF inhibitors. But since then, we have a number of new advanced therapies, which are both oral and biologic therapies that we'll discuss. And this is the entirety of the advanced therapies we have currently approved for IBD. So we have oral therapies, which include Janus kinase inhibitors and S1P receptor modulators. We have injectable therapies, which include interleukin inhibitors, anti-IL-12/23 like ustekinumab, and some of the anti-TNF therapies. And then we have some infusion therapies, which include Vedolizumab and Infliximab. So how do we approach what the best strategies are for some of these medications we have? Now, particularly with the anti-TNF therapies, it's been well established that combination therapy, particularly with Infliximab, is the best approach to treatment. And this has been shown in 2 large randomized controlled studies, one for Crohn's and one for UC. This is the SONIC trial from Crohn's disease, which showed that using Infliximab in combination with azathioprine was superior to using either agent alone. And in the green, you see about a 13% benefit of combination therapy over just monotherapy with Infliximab. And the same thing was shown in ulcerative colitis, where again, similar type of study, randomized to either agent alone or the combination, and you see that combination azathioprine plus Infliximab had an 18% benefit over just Infliximab monotherapy alone. So this is really the best strategy for moderate to severe IBD when using Infliximab. In terms of fistulizing disease, which is one of the most difficult to treat complications of Crohn's disease, Infliximab has been studied specifically in this population. These are the data from the Accent trials. On the left, you see the induction data showing that Infliximab is superior to placebo in terms of treating fistulizing disease, and 90% of these patients had perianal fistulas. And on the right, you see that in maintenance, again, Infliximab is superior to placebo in terms of maintaining remission. And I think a highlight here is that Infliximab is actually the only biologic agent that we have that's been studied specifically for fistulizing disease with fistula endpoints. And that's an important idea going forward, as we need to do more studies with our current agents in these severe phenotypes. Now, there are some potential adverse events associated with anti-TNF therapy. Overall, these are very safe drugs, and I want to really reinforce that. But the questions we often get are about cancers and infections. So in terms of cancers, the main thing we worry about are melanoma. There's a very small risk of melanoma, so we recommend that patients get a yearly skin check and also use protective therapy in the sun. And then lymphoma is also another rare complication with anti-TNF therapy. And to give you some context, your baseline risk of a lymphoma is around 2 per 10,000 patients per year. If you're using an anti-TNF drug as a monotherapy, your risk may go up to about 4 in 10,000 patients per year. So it's a very low absolute risk, but double your baseline. If you're using a combination therapy, we say the risk is around 6 to 8 per 10,000 patients per year. So again, it's a very low absolute risk, but it's increased from your baseline. And then in terms of infections, we check for exposure to tuberculosis and hepatitis B, and we make sure to vaccinate patients prior to use of anti-TNF therapies. The next class of drug that came around after anti-TNF therapy were the anti-integrins for treatment of IBD. And Vedolizumab specifically has some benefits in that it's a gut-targeted therapy. It blocks trafficking of immune cells to the gut specifically, so it doesn't have some of the systemic off-target effects that we may worry about with other therapies. I want to highlight this study, which was a head-to-head study of Adalimumab versus Vedolizumab for treatment of moderate to severe UC, the VARSITY trial. This was actually the first major comparative effectiveness study of biologics head-to-head in IBD. And what you see here is that Vedolizumab was superior to Adalimumab in terms of achieving clinical remission for moderate to severe UC. So in this scenario, you would probably prefer Vedolizumab. The next class of biologics that came after the anti-integrins were the anti-cytokines, and this includes ustekinumab, which is an IL-12/23 blocker. It is approved for both ulcerative colitis and Crohn's disease. It's very effective, and safety profile is probably more on line with Vedolizumab's safety profile. However, this was a recent head-to-head study where they compared ustekinumab versus adalimumab for early, moderate to severe Crohn's disease. And what you see is that both are effective agents, and there was not a significant difference between the two. So both are very good options. And the conclusions from this study, C-View, were that, again, they're both effective and safe options for biologic-naive Crohn's disease, and that it's really important to have a shared decision-making between patients and physicians when deciding which drug to use, and you can consider other factors besides effectiveness since they look about equal in that scenario, such as insurance, coverage, adherence, and patient preference. And again, I just like highlighting these head-to-head studies because we need more of this in IBD. Now, how do I approach choosing the right therapy with a patient for moderate to severe Crohn's disease? Well, here are the available options for moderate to severe Crohn's. We can think about efficacy, where all of the drugs we have available are efficacious for treatment of Crohn's disease. If we're thinking about how rapidly we might expect to see a response, there may be some advantage with anti-TNF therapy and ustekinumab in Crohn's disease. For perianal fistulizing disease, again, Infliximab is the only agent with specific data for perianal fistula, so there's going to be an advantage there. For extraintestinal manifestations, you may move towards more anti-TNF or ustekinumab because these are also approved in other disease states in rheumatology and dermatology, whereas Vedolizumab, while it's gut-targeted, may not help as much with some of the extraintestinal manifestations. However, if you're concerned about serious infections and malignancy, the gut targeting of Vedolizumab may be ideal for you. In terms of pregnancy, probably all these drugs are safe, though I highlight anti-TNF because we have the most data for anti-TNF therapy in pregnancy, a very large study, the Piano Registry, which has really established how safe these drugs are for both the mother and the baby. If you're worried about the formation of antibodies to these drugs, you're going to see less of that with Vedolizumab and ustekinumab than we do with some of the anti-TNF therapies. However, anti-TNF therapies have been around longer, so we have more knowledge about how to use therapeutic drug monitoring and optimize doses with the anti-TNF agents. And then lastly, cost, which I guess nobody really wants to talk about, but we have biosimilars for the anti-TNF drugs, so there may be a cost advantage there. Now, the newest group of therapies for IBD are the small molecules, and these are different than biologics. One, they're small. Two, they're non-immunogenic, meaning you don't develop antibodies against small molecules. They can be administered orally, which is a major advantage for patients, whereas biologics that we have currently available have to be subcutaneous or infusion-based therapies. And small molecules also have a short half-life, meaning that they clear from your system quickly and may also lead to a quicker onset of action. And this is particularly helpful when you're dealing with adverse events and want to wash out a drug from your system quickly. There's a number of different Janus kinase inhibitors in development for IBD. We're going to focus on the two that are approved for IBD. The first drug approved was tofacitinib, which is a non-selective Jak inhibitor. And this is data from the clinical trials of tofacitinib. And without going into too much detail of what's going on here, the thing I want to highlight with tofacitinib was that they showed that the treatment effect was similar in patients who had previously been exposed to anti-TNF therapy as those who had not been exposed to anti-TNF therapy. And this is one of the downfalls of the biologic therapies, is that when you've been previously exposed to a TNF, we seem to see a lower response with each subsequent drug. But it may be different with the small molecules, and data here and also with upadacitinib seem to suggest that. Also, we talked about the short half-life and quick onset with tofacitinib. When they analyzed the data from their clinical trials, you could see an effect of the therapy within 3 days of starting. So decreased stool frequency, decreased rectal bleeding compared to placebo in 3 days. Now, there are some potential adverse effects that we have to consider with the Jak inhibitors. One, in terms of infections, we're particularly concerned about zoster, so it's important to get a shingles vaccine prior to treatment if possible. And then also there's some risk of non-melanoma skin cancers associated with Jak inhibitors. The big concern has revolved around blood clots and cardiovascular events. And this stems from a study that was done in rheumatoid arthritis patients over the age of 50 with at least one cardiac risk factor. It was a post-marketing study where they randomized patients to tofacitinib or an anti-TNF biologic for RA, and they found that the patients in the tofacitinib group had higher rates of pulmonary embolism and cardiac death. So for that reason, there is a warning label on all JAK inhibitors, and use is restricted to patients that have previously failed a TNF inhibitor. Now, I want to put some caution in interpreting this in the context of IBD, because IBD is a very different disease than rheumatoid arthritis. The baseline risks are different for patients in terms of their cardiac profiles. We also know that IBD patients are at higher risk for blood clots at baseline. So it could be that treating the underlying disease of IBD may lower your actual overall risk of blood clots. But this remains to be seen, and I think we have to really consider these potential risks when we're prescribing the therapies. Now, when you have a risk-benefit discussion about potential adverse events, it's always important to weigh those risks against the risk of uncontrolled disease for patients, the risk of being on chronic steroids, and the risk of undertreatment. After JAK inhibitors, the next oral small molecule that was available were the S1P receptor modulators, and these work by stopping lymphocytes from migrating to sites of inflammation. They trap the lymphocytes in the lymph nodes, and this can lead to improvements. And ozanimod was the first approved S1P receptor modulator for ulcerative colitis, approved in May 2021. And you see here its significant benefit compared to placebo for moderate to severe UC, and it's also in late-stage clinical trials for Crohn's disease. Now, there are some contraindications to ozanimod use. If patients have cardiac conduction abnormalities, this would be a contraindication, untreated severe sleep apnea, and there are potential drug interactions with drugs, specifically the monoamine oxidase inhibitors. So how do I integrate small molecules into my practice? And this is specifically for ulcerative colitis, because right now we only have small molecules approved for ulcerative colitis, not Crohn's disease. With the JAK inhibitors, they are generally my preferred second-line therapy in appropriate severe patients who have failed optimized anti-TNF therapy. I consider them, when patients have extraintestinal manifestations, as they are approved for rheumatologic conditions as well. So if you have an inflammatory spondyloarthropathy, that's a potential good therapy. There's some situations where I use a higher dose in maintenance, and these include patients that had a delayed induction period, more severe disease, or when we're treating extraintestinal manifestations, there's some evidence that the higher maintenance dose may be better. I do consider dose reductions in patients who have achieved deep remission, just due to some of the concerns around side effects with the JAK inhibitors, and I carefully screen for thrombotic risk and vaccinate for herpes zoster prior to use. With ozanimod, I consider this in otherwise healthy treatment-naive patients with moderate disease who want an oral option for treatment of their UC. Again, I carefully consider their concomitant medications and see if they have any cardiac conduction abnormalities before treatment. And then there's some groups who you may want to avoid all of the small molecules. This includes women who are considering pregnancy in the near term, because these have not been tested in pregnant patients, and there's some theoretical risk with these agents in terms of pregnancy. And then patients over 65 with cardiac risk factors or a history of cancer may be patients that I would be less likely to use a small molecule. Now, in terms of the overall safety pyramid of medications, this is how I would classify things, and I stole this from my colleagues, Dr. Ruggiero and Dr. Click. And in general, I want to frame that all of the therapies we have are safe, right? Especially the bottom of the pyramid is steroids. So we're trying to avoid steroids, and any steroid-sparing therapy is going to be better than steroids. And always remember that inadequate treatment is an adverse event of therapy. So now let's think a little bit about what the future may hold for IBD. And before we talk about the different therapies, I want to talk about some of the approaches we use. And we know more now that it's not just medical therapy that makes a difference for IBD patients. It's using a team-based approach to take care of IBD patients. We have to take care of their behavioral health. We have to take care of their nutrition. We need to work with pharmacists who can help us explain risks and benefits and help with monitoring of patients. We have to work with excellent surgeons. So it's really important to have this IBD medical home style of care. However, not every center or practice has the capability to provide this type of care. So what may the future hold? The future may be that, IBD medical home centers work with community practices to help do a team approach with those practices, where maybe we provide some of the aspects of care that aren't available locally to patients. And this can expand the overall IBD team-based approach throughout the country. Now, just talking about what are the upcoming therapies you're going to see for IBD, many of these are going to be family members of currently approved therapies. So the next drug that we're going to see approved for IBD is probably going to be risankizumab, which is a IL-23 specific inhibitor. So it has similarities to ustekinumab. And there are actually 4 IL-23 inhibitors that are likely to be approved for the treatment of IBD. And you can see some of these are already approved for psoriasis and psoriatic arthritis. We don't have to get into the details here, but this is just showing you that in terms of induction for treatment of moderate to severe Crohn's disease, all of the upcoming IL-23 inhibitors seem to be effective and have comparable outcomes with ustekinumab, which is, again, an IL-12/23 inhibitor. And then in terms of ulcerative colitis, again, we expect that these IL-23 specific inhibitors will be approved for UC as well, and we're seeing similar responses to ustekinumab. Now, in terms of IL-23 and even IL-12/23, the safety is actually quite good with these drugs. And as I said earlier, probably comparable to Vedolizumab. We see lower rates of antibody formation. From all the studies in various disease states thus far, very low rates of serious adverse events, low discontinuation rates, low serious infection rates. There's been no malignancy signal with these drugs and also no increased cardiovascular events. So I think safety-wise, having all these options is going to be really good for patients. In terms of the Jak inhibitors, we talked about tofacitinib, which was a non-selective Jak inhibitor, but the next thing are actually selective Jak inhibitors. The first was actually approved 2 months ago in upadacitinib, and some of the advantage of selectivity with Jak inhibitors may be that by only blocking mostly JAK1, there could be advantages in terms of hematopoiesis, tumor surveillance that maybe lead to decreased side effects. And so upadacitinib, again, was approved in late March for treatment of ulcerative colitis, and we'll talk a little bit about Crohn's disease as well. But in terms of UC, the data for upadacitinib was actually really good. You see here in the middle that response rates over 70% with upadacitinib, so that's really, really impressive. And then filgotinib is another selective Jak inhibitor, which we may see in the future. Here I'm showing some of the data for Crohn's disease. Now, tofacitinib did not meet its primary endpoints for the treatment of Crohn's disease, though we still do use it in select treatment refractory cases and see some benefits. This is the induction data for upadacitinib in Crohn's disease, and what you see here is that upadacitinib seems to be very effective for the treatment of Crohn's disease in addition to ulcerative colitis. On the left, the study UEXCEED included patients who had been exposed to biologics as well as patients that had not been exposed to biologics. And on the right, you see the study was filled with patients all who had previously been exposed to biologics. And importantly, as I mentioned earlier with tofacitinib, the treatment effects appear to be the same independent of their prior biologic use, which is important. And just this past week, actually, they released the top-line results from the maintenance studies, which also were very positive. So I expect that you'll see upadacitinib for Crohn's disease either later this year or early 2023. We're also going to see different formulations of some of the same drugs that we currently have available. So we'll have Vedolizumab self-injections soon. These are already available in Europe. Induction dosing will be intravenous infusion at weeks 0 and 2, and then you'll get maintenance infusions every 2 weeks. Not infusions, maintenance injections every 2 weeks with Vedolizumab. And so this will be important in terms of some of the convenience of administering the medication. We're used to seeing biosimilars for Infliximab, but in 2023, we're also going to see biosimilars for Adalimumab. And it's important that these are going to be interchangeable, meaning that they could be substituted by the pharmacy for your parent drug, Adalimumab. And if you're wondering if substitution is allowed in your state, well, 45 states in the country do allow substitution, including Ohio. In addition to some of these other therapies, we are going to see new biologics trying to target specific severe phenotypes of disease. So I highlight this study of spesolimab because this is going to be the first study specifically looking at treatment of stricturing Crohn's disease. Usually stricturing is a exclusion criteria for the clinical trials in IBD, but here we're going to be looking at a drug specifically for treatment of patients with Crohn's disease strictures. And then I want to end with the idea that the era of a one-drug-fits-all approach may be over for IBD therapy. And so these are results from the VEGA UC trial, which was the phase 2A trial presented earlier this year. And this looked at combination anti-TNF along with anti-IL-23 therapy versus treatment with either therapy alone. And what you're seeing is that in moderate to severe UC, there was a significant benefit to the combination approach over a monotherapy approach with either agent, and there wasn't a signal for serious adverse events. And actually, phase 3 studies are starting of this combination approach for both UC and Crohn's disease. And then, if we think about how we treat an IBD versus, say, cancer therapy, in IBD, we tend to give all patients the same drugs with some variation of aggressiveness and factor in risk of side effects and practicality and costs. And we generally get a remission rate around 30 to 40%, and we don't have a cure. Whereas in cancer, they check a genotype, they stage the patient with imaging and all sorts of other tests. They analyze the biopsies for receptor expression to choose targeted therapies, and they're able to get cures in many patients by taking this targeted, individualized approach. And there really isn't a reason why we can't use a similar methodology with IBD. So if we take the population and we can clinically profile them and group them into different categories, and then we can do molecular profiling of the patient, and ultimately this can lead to a precision therapy-based approach for IBD patients. So I think if you think in the long term, this is where we may be heading. So my take-home messages for today are that, one, undertreatment of disease activity, delays in treatment, and chronic steroid use are associated with more adverse events than appropriate medications started at the right time. And the future of IBD will involve more access to multidisciplinary care, more treatment options, and a more rational approach to how we select treatments for different patients. And with that, I will end, and thank you for having me.